Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. This is Steve Caselli, Executive Director at the International Cardio-Oncology Society. I'm here with our founding director, Dan Lenihan. We are at the Memorial Sloan Kettering Cardio-Oncology meeting, and we're here with one of our colleagues, Dr. Tom Neilan. And we're going to talk with Tom a little bit about the ATRIUM trial that he is the principal investigator on.
So, Tom, this is always a great opportunity for us to hear about how you're doing with different things, but in particular the ATRIUM study. We're very interested in that, obviously, and you know, I know that we talked about this trial years ago in our scientific committee, and you presented your thoughts, and we kind of gave you some feedback. It's really amazing to see where it is now. So it's like you got to see it right at the beginning, and now we're kind of deep into it. So tell us about
Thanks, Dan. We are fairly advanced in the trial. At this stage, we are open in 48 centers throughout the United States and Canada. And the level of engagement from the cardio-oncology community has been remarkable. I think what's most notable and what's most impressive is the way at each of these major academic centers that many oncologists and many cardiologists come together to try and provide answers to these patients for whom there are not a lot of answers. We're open at 48 centers, as we've spoken about, in the United States and Canada. We have an intention of opening at a few more centers, so our final number of centers will be a little over 50. We're currently at either 69 or 70 patients enrolled. Don't hold me to that exact figure because it changes thankfully on a relatively frequent basis. And to put that number of 70 enrolled in context, in the immunotherapy toxicity space, it is already the largest randomized clinical trial in the immunotherapy toxicity space of any toxicity related to immune therapy. It is clearly, by default, the largest randomized trial in the myocarditis related to immune checkpoint inhibitor therapy space. And it is well on its way to being the largest randomized trial in any myocarditis space. And it's all about the engagement. It's all about the community. It's all about people like you who have supported the trial and who recognize the importance of the high level of evidence that comes from the rigor of a double-blind, placebo-controlled clinical trial.
Yeah, I mean, there's so many pieces to discuss further, but my first is just the general astonishment that, number one, you had this idea and you pursued it through all these different avenues, and here we are. It's actually growing up in front of you. So that's really just an amazing testament to your commitment. So thank you for that. The other most impressive thing to me is, you know, I sort of grew up in the advanced heart failure space for many, many years. And whenever I was struggling with making the diagnosis of myocarditis, just clinically, it was a challenge. You know, whether you decided that it was related to some viral exposure or some autoimmune problem or some other cause of what appears to be myocarditis, a lot of times, you know, you do all these tests and weeks go by, maybe even months. And then finally, in the end, you say, okay, yeah, I think this person had myocarditis. Or on the alternative, you say, no, I think it was something else. I really don't know. And I would say that across the board, whenever I was considering the diagnosis of myocarditis, I probably only really made that diagnosis 20% of the time. That's just a rough estimate in my mind. So you take that backdrop and then you apply it to patients with cancer that are getting immunotherapy that is potentially life-changing, life-saving. and you're coming up with what appears to be a very serious diagnosis, how does that fit in your mind in the sense of how challenging is it to even make that diagnosis, then let alone design a trial to treat it most appropriately?
Those challenges that you've faced as a heart failure doctor all along remain. And so there's no perfect way. The only perfect way to make the diagnosis is sadly through autopsy. But autopsy aside, no test is perfect. And so a lot of it is putting the pieces of the puzzle together and saying, this seems like myocarditis. Sometimes it's very easy. First or second cycle of immunotherapy, patient presents in cardiogenic shock. They're relatively younger. You don't suspect you don't expect anything else like accelerated atherosclerosis, etc. Those times it's fairly straightforward. Most of us would make the diagnosis. But the challenge happens to be in the more subtler cases, the milder end of the phenotype. What do you do with the patient who's got lung cancer, who's short of breath, who tells their doctor they're short of breath, but they've always been short of breath? Somebody checks biomarkers. Their high sensitivity troponin is elevated, it's detectable. It's not egregious, but it's certainly detectable. EKG is non-specific, very common scenario. Ejection fraction is normal, very common scenario. What do you do with that patient? That's the real challenging patient. And can you safely dismiss that patient as a low-risk phenotype because of all the testing you've done? Or is that patient still at risk of adverse cardiac events? And this entire immunotherapy toxicity space is very humbling. That is the message I give to everybody. It is very humbling. Because in general, they're difficult diagnoses to make. For years, myocarditis has been a difficult diagnosis. This is especially difficult when you consider the overlap you said, which is so important, of the presence of cancer.
Yeah, I think that concept right there is a pretty daunting task if you're trying to separate out a life-threatening diagnosis that is going to seriously impact their subsequent cancer therapy. You certainly don't want to take it lightly, and I'm not suggesting that you are, but it's a real difficult space. So tell me about that. If you design this trial and you say, we have patients that presented with myocarditis based on criteria A, B, and C, whatever you said they were, and then you're going to randomize them to specific therapy for that myocarditis. How did you come up with that, or where did you get to that spot?
The base therapy for myocarditis we got were corticosteroids, and that getting to that part was easy. In that all the guidelines recommended high-dose corticosteroids. All the guidelines recommended high-dose corticosteroids. So that part was straightforward and easy. What the dose of corticosteroids was as the standard of care, that was a challenge because the guidelines are not consistent, and the guidelines are not consistent because there are not great data out there to help guide people. And so guidelines have suggested, they all say high dose. What does high dose mean? According to ASCO, initial therapy is 1 to 2 milligrams per kilogram of prednisone. According to ESMO, it's 500 milligrams of solumedrol. According to NCCN, it's 1,000 milligrams of solumedrol. According to SITC, it's 1,000 milligrams of solumedrol. That's a wide range there, even for what we define as standard of care. How did we come up with the idea of abatacept? That was a little more straightforward. There were lots of case series out there about the use of abatacept. There were lots of case series, case reports. There was a very elegant basic science paper published about the use of abatacept, led by Dr. Allison, who won the Nobel Prize for CTLA-4. And so there were a wealth of data suggesting that abatacept might be a reasonable option. The other reason we thought about designing the clinical trial is that when you look at second-line options for immune checkpoint inhibitor myocarditis, a list of options comes up in each of the guidelines, and that list of options is not those list of options are not the same in each of the guidelines. And so we recognized that there was an evidence gap. We recognized that there were preliminary data to support the use of abatacept. But we also recognized that to truly move the field forward needed a randomized clinical trial. No trial is perfect. Everybody should acknowledge that from the outset. And that's also true for the ATRIUM trial. No trial is perfect. However, it's a start. And also what the ATRIUM trial tells us is that as a community, we can come together and do randomized clinical trials. I think that latter bit is super important.
Oh, I couldn't agree more. Just pulling that all together and actually doing it it's just a tremendous achievement. And that in and of itself, I would say almost regardless of what you find on the data, it will be very helpful. It will be helpful for all of us about making decisions in the end, whether abatacept is the right next therapy or, dose, etc. Those are things to be found out. But honestly, just pulling everybody together is really an awesome achievement. And thank you for doing it. I think the other part that I would also bring up is, years ago, you probably remember this, but there was a myocarditis treatment trial, which was in cardiomyopathy, heart failure space.
Sure.
And they basically said anybody with new onset cardiac dysfunction without coronary disease, that was their definition of myocarditis. And then they treated them with steroids, or I think it was placebo. I can't remember, but I believe it was prednisone versus placebo. And there was no benefit to prednisone in that study. But when you look at the details, you go, well, not very many of those people actually had myocarditis.
Sure.
So who knows if prednisone's even helpful in that setting? You can't tell because it's a complex space. So in your patients that are enrolled in this study, how confident are you that they have myocarditis?
Short of autopsy, there's no way to be 100% confident.
No, I wouldn't expect that. Yeah.
However, to try and exclude the possibility of over-treating and over-diagnosing, we did two things. One is that we said to get into this study, you need either histological evidence of active myocardial inflammation and cell death. Number one, or you needed an elevated troponin plus a few other features, either an MRI which says there's active myocardial inflammation, or suggestive MRI with another form of itis, right, such as myositis or hepatitis. The reason why we have a little bit of more comfort than those original myocarditis trials is we have a definite inciting event. And that's the key difference here. The patients all get on immune checkpoint inhibitor therapies. A lot of those patients who presented with cardiomyopathies related to myocarditis, the inciting event could have been very remote and the levels of active inflammation were probably low. Here the hope, the levels of active inflammation remain high.
No, that's a great point. In referencing the myocarditis treatment trial, the rate of biopsy evidence of myocarditis was only 10% in that particular study. So again, it wasn't a very hot population, where in this setting, these patients are very hot because they've been getting immunoactive therapy and they develop a cardiac-based syndrome. So yeah, I think it's an excellent design in general for as difficult as the space is.
Yeah.
So
it is a challenging space, though, And the question you raised earlier a little bit about the corticosteroids, that is something that we keep thinking about. Wouldn't it be? And I'm going to take a little bit of a step further. There are real concerns that high doses of corticosteroids, even 1 to 2 milligrams per kilogram of prednisone, is associated with worse cancer outcomes. And so even the lowest of the suggested regimes is associated with worse cancer outcomes. Who knows where the ATRIUM trial is going to go? Who knows what it's going to find? But ultimately, I would love to get to a stage whereby we could better phenotype the patients, decide who doesn't need any treatment, who needs a reduced dose. Or we were in a study there where they were talking. We were in a presentation just there where they were talking about reduced intensification of cyclophosphamide. Maybe there are patients out there with myocarditis, and there likely are, who will do fine with lower doses of corticosteroids, will do fine with lower doses of corticosteroids in combination with another biologic. And then there are patients for whom will require high doses of corticosteroids and multiple biologics. And that would be an amazing outcome from the ATRIUM trial, to try and parse those different patients apart, to say, yes, you'd probably be observation alone. You probably low-dose corticosteroids or low-dose corticosteroids plus another biologic which doesn't impact cancer outcomes. And you then, sadly, this patient phenotype is the high full core press, needs everything. I anticipate that that's the future. That we will find a reasonably sized population whereby we can get away with reduced dose corticosteroids plus a biologic.
No, that's fantastic. And as I said, the whole concept of the trial and the actual, basically the delivery of the trial has been just an awesome achievement. So I do want to put whatever updates you're able to put on there, on our website, just so that we can help to continue to raise awareness.
Great.
And for sites that are considering enrollment, engagement in the trial, that, we want to encourage them to really participate. And I mean, that's what we're all about, in the sense that for us to really improve the care of patients, we need to share our information. We need to, and try to do it in as disciplined a manner as we can. And
absolutely,
everybody learns from each other. So as you know, I frequently call you or ask you, what do I do with this patient in front of me? But that's why I want to know you. So there you go. So. But no, we appreciate your efforts, and any updates that we can put on the website, we're happy to do it. So.
Great. Thank you.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.